Thank you, sir, for this kind introduction. Am I audible?
Yeah, you can start.
Yeah, thank you, Sanjana ji, for inviting here. It's a great pleasure to be again seeing you and interacting with you. And it's always nice to hear what the parents and their perspective is. So with that, we'll share our little experience with steroid therapy and what the latest research is going on the steroid therapy in children with Duchenne.
Yeah, that's fine. Perfect. Yeah, thank you.
So I will be giving a brief overview of Duchenne, which is basically the most common muscular dystrophy in childhood, and it's a kind of progressive disease. So most of the literature is related to Duchenne, so we'll focus on that. So I think we have all known that it's the most common muscular dystrophy in childhood onset, with the incidence of around 1 in 5,000 boys. Typically, the age of presentation is 4 to 5 years, and is secondary to mutation in a dystrophin gene, which is present on the X chromosome at 21 location. So this is a basic pathogenesis. What happens because of mutation? There is an absence of dystrophin, but it can affect various organs also, like brain, but predominantly it affects the skeletal muscles as well as the cardiac muscles. So basically what the dystrophin protein does, that it connects the muscle fibers, contracting protein and the sarcoplasma. Yes, sir.
Sorry to interrupt you. अगर आप थोड़ा हिंदी में भी अगर बात कर सके, अगर संभव हो तो देख लीजिए.
Right, sir. Right.
Thank you.
Okay. Yeah. So this dystrophin protein actually, ये ये जो काम करता है, basically it जो मसल के सेल की वॉल है विद जो प्रोटीन्स कॉन्ट्रैक्ट करते हैं, जिससे हम मसल में फोर्स जनरेट करते हैं, उनको आपस में जोड़ता है. सो व्हेन द डिस्ट्रोफिन प्रोटीन जब एब्सेंट होता है या ये डैमेज्ड है या छोटा बना हुआ है, तो वो कॉन्ट्रैक्शन जब मसल हर बार कॉन्ट्रैक्ट करती है, तो इट डजंट कॉन्ट्रैक्ट वेरी फोर्सफुली एंड इट लीड्स टू डैमेज टू दोस प्रोटीन फाइबर्स. सो इस डैमेज की वजह से देयर इज अ सेल्स हैं, दे कंटिन्यू टू डाई. उसकी वजह से मसल स्मॉल होने लगते हैं, दे बिकेम फाइब्रोज्ड, दे बिकम वीक, एंड सिमिलरली इट मसल जब टूटते हैं तो ब्लड में सीके के लेवल्स बढ़ जाते हैं, जो सीपीके का टेस्ट हम करा के देखते हैं, जो कि काफी डिस्ट्रोफीज में बढ़ा हुआ होता है. और ये कई बार हार्ट को अफेक्ट करती है, तो जब हार्ट की मसल्स का डेथ होने लगता है, तो हार्ट ऑल्सो पंपिंग कैपेसिटी उसकी कम हो जाती है. सो दिस इज द बेसिक ये कारण है कि वाई डिस्ट्रोफिन जीन की एब्सेंस से इतने सारे मसल वीकनेस और इतने सारे सिम्टम्स होते हैं. कई बार ये ब्रेन को भी अफेक्ट करते हैं. सो कई बार इन बच्चों चिल्ड्रन विद डुशेन जो होते हैं, they can have a slightly lesser IQ, autism spectrum disorder, or they can have cognitive issues also. So this is how this dystrophin protein looks, and it has got several of the segments which joins the जो कि सेल मेम्ब्रेन से ज्वाइन करते हैं, और एक इसका पार्ट जो होता है एक्टिन प्रोटीन से जुड़ता है, जो कि कॉन्ट्रैक्शन के लिए काम आता है. सो दिस इज ओवरऑल स्ट्रक्चर. बट जब भी जीन में ये म्यूटेशन आती है, तो दिस प्रोटीन ये बीच में से कहीं से टूट जाता है. सो देन द प्रोटीन इज नॉट फंक्शनल, उसका कोई ना कोई पार्ट मिसिंग है. सो इट कैन नॉट डू, ये वो काम नहीं कर पाता प्रॉपरली जो इसको मसल के साथ करना चाहिए. सो दिस इज हाउ दिस, इस डायग्राम में आई जस्ट वांटेड टू शो कि ये मसल मेम्ब्रेन है और ये कॉन्ट्रैक्टिंग प्रोटीन है यहाँ पे, एंड ये डिस्ट्रोफिन का प्रोटीन ये इन मसल मेम्ब्रेन को इस प्रोटीन से जोड़ने का काम करता है. एंड इसमें जब भी कोई म्यूटेशन होती है, तो ये यहाँ से ब्रेक हो जाता है. सो दैट्स व्हाई ये वॉल और कॉन्ट्रैक्टिंग प्रोटीन आपस में इंटरेक्ट नहीं कर पाते, और इस वजह से मसल डैमेज होने लगती है. सो ये बेसिक पैथोलॉजी है इसके अंदर. वी कैन सी द एग्जांपल. ये नॉर्मल मसल बायोप्सी दिखती है ऐसे. It's nice pink and uniformly stained, but जो डिस्ट्रोफिन के अंदर क्या होता है, जैसे मसल्स फाइबर टूटने लगते हैं, तो दे गेट स्मॉल, राउंडेड, एंड दे ऑल आर फिल्ड विद फैट एंड फाइबर्स, सो दे गेट रिप्लेस्ड. इसलिए वो डैमेज होने लगते हैं. डैमेज होके दे गेट रिप्लेस्ड विद फैट एंड फाइबर्स. सो क्लिनिकल फीचर्स ऑफ मस्कुलर डिस्ट्रोफी में क्या रहता है? ड्यूशेन में टिपिकली बच्चा दे स्टार्ट वॉकिंग लेट, they have उठने में उनको समस्या होती है. Normal बच्चों से they cannot compete or they cannot run, they do not participate in athletics, and later on they have difficulty in walking upstairs, frequent fallings, and they develop toe walking, and often they have a short stature also. So diagnosis is usually made by 4 to 5 years of age, and sometime brain की भी issues उनके साथ में रहते हैं, जैसे behavioral issues, autistic features, or there may be less IQs in these children also. So this is a typical posture of children with Duchenne muscular dystrophy when they walk. Like they have unka abdomen is protruded, they have a calf which looks bulky, mote calf hote hain, unke calf muscles looks very bulky, and they walk on toes. Basically heel is high, and usually shoulders are पीछे की तरफ होते हैं. So this is a typical appearance of the children with the Duchenne who is like in advanced stage. Sometimes muscles looks bulky, but they are not actually strong muscles, they are weak muscles. So most common muscle are hypertrophied are calf, infraspinatus, deltoid, and other muscles, sometimes tongue is also hypertrophied. These are the some typical signs जो हम इनमें देखते हैं. Like this is the Govt sign which is typically seen in Duchenne. Once you एक बार हम जब उसे बच्चे को बैठ के उठ मतलब lying down posture से खड़े होने के लिए बोलते हैं, तो they have this kind of maneuver to get up. जब वो नीचे से जमीन का support लेते हैं, then they rise on themselves, and this is a valley sign which we see when we examine these children. This is because of कुछ muscles are hypertrophic, कुछ muscles are atrophied, and they are weak. This is a typical course and transition in DMD. किस तरह से symptoms onset होते हैं, and it passes through the 5 stages of disease. Like early childhood में there are very less symptoms. Then by 4 to 5 years they have symptoms of उठने बैठने की दिक्कत, उनका चलने का तरीका बदल जाता है. There is a difficulty in going upstairs. बाद में they have difficulty in walking, and then they are not able to get up from the floor, but still they are able to walk. Later on they become wheelchair bound, and later on they develop other complications like scoliosis and weakness of upper limb also. So dystrophinopathies, DMD or Duchenne, it has a broad spectrum. Like there could be severe and Duchenne, there could be milder and like Becker's or intermediate, or sometimes they can just कई बार सिर्फ ये calves को heart को affect करती है alone, और कई बार ये females में भी symptomatic हो जाती है. So treatment of these muscular dystrophy is usually multidisciplinary. वहाँ पे जैसे you need to have lots of people to help the patient, और कुछ लोग medicine का decision लेते हैं. Some help with physiotherapy, some helps with orthotics, and cardiologists, geneticists. So lots of people are required to help these children. And as the disease जैसे जैसे progress होती है, different aspect of disease require different specialities. So this is the how the care is structured. Basically diagnosis is made by neurologists or physicians, and then you need help of all these ancillary persons like physiotherapists, cardiologist, bone issues, and social support. So this all is required to manage these children. Since there is no absolute curative therapy which can cure the disease, there are lots of supportive stuff is required to these children, like ambulatory devices, shoes, orthotics. Then sometimes if the spine gets curved, then the fusion is required, respiratory support is required, and sometimes feeding tubes are also required. So now I'll come to steroids, how the steroid therapy has emerged in Duchenne. Basically, it was started in around 1990s, where the people have started noticing in biopsy that there is lots of inflammation. वहाँ पे बहुत सारे cell हैं जो muscle पे attack कर रहे होते हैं. So that's why people started using steroids. So till now, steroids is the mainstay of therapy. There are some new drugs, but actually they are not available to all the patients right now. So the treatment is anchored towards steroid therapy in Duchenne right now. And even if they goes to some rare kind of gene therapy or exon skipping therapy, steroid remains a standard of care that has to be there. And after that only you can go for any kind of additional gene therapy or advanced therapies. So this was first published paper in 1989, where they studies the steroid in children with Duchenne. जब उन्होंने they have seen that given children Duchenne ko, they given prednisolone or deflazacort, and prednisolone, and one arm received prednisolone, other arm did not receive any therapy. So they saw that by 6 months they could make out that these children was better. Their walking ability was better. Their time to stand was less. Their falls were less. However, there was a concerns of weight gain was there. So steroid, how does steroid acts in muscular dystrophy? That is also not very well understood, but it is said that it has got anti-inflammatory effect. What it does that it stops the जो सेल आके मसल्स को अटैक कर रहे हैं, जो मसल्स फाइबर डैमेज हो जाते हैं उन पे आके अटैक करते हैं, एंड दे मेक द मसल फाइब्रोटिक. सो स्टेरॉइड का काम है कि वो उन सेल्स को दे रिड्यूस दैट सेल्स अटैक, and hence they reduce the fibrosis and they reduce the progression of the disease for some time basically. So biopsies और उसमें ये देखते हैं कि when they treat with steroid, the inflammation या उनके अंदर जो attack of cells है वो कम हो जाता है. So अभी recently there are some research that can we have some steroid which acts on the cell but do not have adverse events. So this is how they are trying to sort out. Like this is a standard steroid regimen which is like prednisolone or deflazacort जो सभी पेशेंट में यूज करते हैं. वो सेल पे काम करते हैं but साथ में they act on other genes also which leads to adverse events, but they are now trying to make steroids which do not act on those genes which causes adverse event but just selectively act on anti-inflammatory effects. So there are some new steroid variants has also been identified, but they are in the studies only. So what the benefit of steroid has been observed that at least those patients जो 1 साल जिन्होंने steroid लिया है, they have their walking capacity increased approximately to 2 years, and जो कि like they have received steroid therapy for more than 1 year, and when it was started early in their life, their walking capacity increased up to 13.9 years, like they can walk additional for 4 years. So that's the effect of steroid what has been observed over periods. काफी लंबे समय से these, you can imagine from 1990 the data is being collected. So last over 20-22 years the steroid data has gradually emerged. Data ये show कर रहा है कि if they receive steroid then the walking capacity remains increased from 1 year to 4 years. So basic are what are the typical benefits that they walk for longer time, their hands are preserved for longer time, their breathing capacity is better, they do not go for ventilators early, and their spines remain stable. They do not require a surgical fixation or surgery, spine की उनको requirement नहीं होती है. But what is the problem that long-term data, long-term efficacy is not known. So since they improve the course for 2 to 3 years, but after that their effect is not sustained, so eventually they again progress the disease. And in addition जब फायदा करती है तो they also has lots of adverse events or side effects which are sometimes can be problematic to the parents or child itself. So some questions are there कि when to start, कब शुरू करना है, if you want to start कौन सा steroid use करना है, which regimen has to be followed, like daily देना है कि alternate days देना है कि weekend में देना है. If we are starting steroid, how do we explain parents की what are we expecting actually, हमें क्या फायदा हो सकता है, एक बार start कर दिया तो कितने साल देना है. And these are the some of the questions which are commonly asked. These are common questions. And we know कि steroid अगर हम normal person को देते हैं तो they become weak, sometimes muscles become weak, but when we are given in dystrophy then why they are not getting weak, they actually improve. So some of these questions are there which are not answered till now. So I'll try to take some of these questions during my presentation so that we all understand that why it is a standard of care at present. So first question is like when to start. So the issue is that when we start late, the efficacy is not that much. But when we start early, then the ambulation can be prolonged up to 4 to 5 years. So what we have seen in studies that children with Duchenne, Joki, they started on steroid between 2 to 4 years. They remain ambulatory at 16 to 18 years. So That's how the impact of early initiation of steroid is there. So right now, what is the practice that once they start declining, like जब बच्चा when they start कि गिरना शुरू हो गया है, he has really difficulty, उठने में उसको problem आ रही है, जब weakness progress हो रही है, अभी current like practice is that you start when they start declining, जब वो weakness आने लगी है तब start करना है. लेकिन study shows that जब बच्चा asymptomatic है, like by 4 to 7 years, very early, 2 to 4 years, if you start steroid then and maintain them for those 15-14 years, the ambulation can go up to 16 to 18 years. So like 16 to 18 years tak patient chalte rahe. Only one patient of one of them has lose milestone. Baki rest of those who were started early steroid continue to walk by 16 to 18 years. But the parents' concern was their height was low, they remained short stature, and they had delayed puberty. Like natural adolescent development was delayed in these cases. So right now one study is going कि 4 to 7 years में steroid शुरू करेंगे तो उनका क्या impact है. So this data is yet to come, but what we know that if you start early, the effect जितना हम जल्दी शुरू करते हैं muscles पे impact उनका लंबे समय तक रहता है. This is about when to start. Now which steroid to start? So typically दो तरह के steroids हैं जो commonly use करते हैं, prednisolone and deflazacort. Deflazacort has been approved, this is approved by FDA in 2017 for as a treatment in boys with Duchenne, जो कि more than 5 years old है. So दोनों में difference ये है कि prednisolone it says that efficacy of deflazacort is better. Deflazacort से जो है weakness progression कम होता है. Prednisolone भी effective है, but prednisolone has lots of side effects, जैसे weight gain हो जाना, and they become short statured or sometimes Cushingoid appearance, behavioral side effects, bone side effects. These are slightly higher with prednisolone as compared to deflazacort. So right now people are switching from prednisolone. अभी जो है वो trend ये है कि like they start them on deflazacort. Previously we used to start them on prednisolone. So now the next question is, if you start, you've selected one drug, you have seen the child, उसको किस dose पे शुरू करना है. So old studies have described that minimum dose was 0.3 mg per kg, but as the dose increases, the response is also increases. So is that role in non-ambulatory children? So that's also is proven that अगर बच्चा चलना भी बंद हो गया है, but still if you start them on low dose steroid, they have preserved function of, उनके हाथ के function ठीक रहते हैं, उनका scoliosis नहीं बढ़ता है, spine में टेढ़ापन नहीं बढ़ता है, and they breathing के लिए उनको respiratory support या BiPAP या machine की requirement कम पड़ती है. So these are the recommendations by international society कि कब शुरू करना है. So like they recommended कि you should start steroids in children with Duchenne. दोनों शुरू कर सकते हैं, deflazacort and prednisolone. And the prednisolone का issue है कि it has a higher weight gain, but deflazacort का issue ये है कि it increases cataract, मोतिया का incidence deflazacort से ज़्यादा होता है. But you need to keep on monitoring children who are started on steroids. And in this graph you can see that like की क्षमता कब खत्म हो गई, और जो जिनको steroid less than 1 month मिला, and जो red bars हैं they shows कि those who have received more than 1 year of steroid. So this is a age bar नीचे, this is a age when they started losing milestones of चलने की क्षमता. So if we can see in this graph that those जिन बच्चों को steroid एक महीने से भी कम मिला है, they lost ambulation by 10 years of age, 10 साल की उम्र में. लेकिन जिनको they receive more than 1 year of steroid, you can say they are ambulatory by 13 to 14 years of age. So this is how the effect of steroids is there. And this is the नीचे वाला graph shows कि उनके हाथ के function कैसे रहे. So this is again जिनको steroid कम मिला है, उनके हाथ के function भी खत्म होने लग गए by like 10 years and 15 years, but those who have received steroids still can had hand functions like They can still operate mobiles, they can still operate, they can eat by themselves, hold a cup of glass by 20 to 25 years. So these are the effects of steroids. So how to start actually? So we discuss with the parents the side effects कैसे रहेंगे उसके और उसका efficacy क्या रहेगा, and then you discuss with dietitian कि उनका ज़्यादा weight gain नहीं हो, they should have a good diet which is fat free and good in protein, and then you decide which one to start. Cost wise, the Deflazacort is slightly expensive. Prednisolone one is cheaper one. So based on your situation, but right now we are starting all, सभी बच्चों को we start on Deflazacort. Then you see and follow every 3 monthly and see कोई side effects है या नहीं है. If you feel side effects है, you reduce the dose to 25% in each visit. If you feel that is tolerating well, then maintain on that dose. ये तो हो गया जो चलते हैं बच्चे. जो नहीं चलते उसमें भी we can use Deflazacort, but on a lower dose, just to maintain उनके हाथ के functions ठीक रहे, उनकी back ठीक रहे, उनकी breathing pattern ठीक रहे, ये चीजें हैं. So this is how we use this steroid. जिनको steroid मिलते हैं उनको we explain कि they can, what side effects they can anticipate. उनको हम eyes checkup कराते हैं, cardiac checkups कराते हैं, bones के checkups कराते हैं, and we keep a watch कि क्या side effects हो रहे हैं, and depending on that we take a call कि what we have to do. So these are the common adverse events जो हम steroid के साथ देखते हैं, like weight gain, they have a Cushingoid appearance, blood pressure change हो जाना, बढ़ जाना, थोड़ा behavioral issues like गुस्सा, irritability. Then short stature is another problem. जिनको जल्दी steroid शुरू करते हैं उनकी height actually कम होती है. Then pubertal delay, adolescent के features जो आते हैं वो कई बार delay हो जाते हैं. कई बार blood sugars are high and cataract. These are adrenal suppression, like infection के समय they can be really weak. So these are the side effects which tell the parents, and we keep on waiting with regular monitoring for blood pressure, weight, height, and by 13 to 14 years we send to endocrine for उनके adolescent के changes के लिए. Sugar we continue to monitor, and every 6 monthly we have an eye checkup. So these are the recommendations, but you see overall word में the practice very differs very much. So in this study what they have seen कि 29 different तरह के steroid use किए जा रहे हैं, मतलब अलग अलग regimen, कोई low dose use कर रहा है, कोई high dose use कर रहा है, कोई daily use करते हैं, कोई 10 days off and on use करते हैं, कोई weekend में use कर रहे हैं. So practice is not uniform across the world. There is lots of variability in using steroids in Duchenne, but most of the centers are now using Deflazacort at 0.9 mg per kg, and some are using weekend like Saturday, Sunday doses also. So right now, if you see in this clinical trial, 23 studies are going, and you see answers of steroid is still not like very much convincing ki, which regimen is best, how to use. But what the evidence suggests कि daily therapy is the best, and you start at 0.9 पे शुरू करके, if you have side effect, come down on the dose and start early, तो उसका benefit ज़्यादा होता है. So Deflazacort के regarding like which one is better, so Deflazacort has been found कि ये better है, because the walking capacity was children with Deflazacort जिन्होंने receive किया, they continue to walk for more years. So this is the meta-analysis which shows that all you can see this bar is in favor of Deflazacort. Like all those who have received Deflazacort, their ambulation of loss of ambulation was increased by 3 to 4 years, like 3.8 years gain हो गया उनके चलने के capacity में. These are other scores which you use in the clinic, like 6-minute walk कैसे है, उनका running time कैसे है, standing time कितना है. So this is how we saw. So most of the parameters was showing कि Deflazacort has a better efficacy. It's got more efficacious. So now one more steroid has been discovered, but that is Vamorolone. So basically it is a variant of Deflazacort, or what they have done ki it binds on only those receptors or gene which has anti-inflammatory effect, और वो उन पे नहीं bind करता जहाँ से हमें side effects expected होते हैं. So it is noted that Vamorolone has less side effect on growth, adrenal, bones, and hypertension. These are not less seen with Vamorolone, but it is in the phase 1 and 2 trial only. So you can see in this diagram that a normal steroid bind to this receptor and it acts on so many parts of the cell, but vamorolone alone binds to this receptor and has only anti-inflammatory effect. And some other variants are also being identified. So just one example, this phase 2 study of vamorolone. So what they have done कि उन्होंने 4 से 7 साल के बच्चे जिनको स्टेरॉइड नहीं मिला था, they have enrolled that 6 mg per kg dose उन्होंने 30 months के लिए दिया, and they compared it with the other group which were receiving other forms of steroid. So what they have noticed कि उनकी height was not affected, they continue to grow in the height, and other side effects जैसे sugar बढ़ जाना, bones weak हो जाना, adrenal suppression, ये इस group में कम था. So this is in still studies, but eventually this will also come into the market. So we'll have a better steroid जिससे कि side effects कम होंगे और desired effects we can see in these. So this is our experience with steroid therapy. This was a data from 2018. So at that time we were starting them on steroids, prednisolone, and most of the children in our receive daily steroid, like daily dose. And previously deflazacort we used to tabhi use karte the when we have more side effects with prednisolone, but now we have switched it to deflazacort only. So this was the doses we are used, and median age जो हमारे patients की थी that was 10.1 year. But इसका reason ये था कि presentation हमारे पास late थी and they started on steroid by 8 years or 9 years of age. But हमारा data showed कि जिनको भी हमने start किया था they continue to use, 72% patient जिनको start किया they continue to use. Some adverse events are there, and but we managed them. So these are the common adverse event what we have seen is like weight gain, change in facial appearance, blood pressure, cataract, bone weakness, and sometimes pressure in the eye. So these are the some of the side effects we have seen. Then we studied in our own patients with the deflazacort which dose is better. जो 0.9 high dose recommended है या we can use a lower dose. So we used a lower dose of 0.45 and compared with 0.9. So what we have seen that 0.9 is 0.9 mg में ज़्यादा effect था, but 0.4 was also not very much bad. So children with 0.4 also improved, but the improvement was higher with the 0.9. So the dose, what we say that you use at least 0.6 to 0.9 mg per kg. If you have side effects, तो उनको कम करके देख सकते हैं. This we have studied ki what is the impact of steroids or in our children who are on steroid. So what we have seen that our 90% children were deficient in vitamin D, and we did bone density, and almost 50% mein bone density was low, and 6% they also had fractures. So this is a high because once the fracture happens, तो बच्चा will be like not able to walk after that because एक बार वो नॉन एम्बुलेटरी हो गया तो दे डोंट इम्प्रूव, स्पेशली जब लोअर लिम के फ्रैक्चर्स होते हैं, लाइक लोअर लिम बोन्स के. अपर लिम के होते हैं तो ज्यादा इफेक्ट नहीं होता, बट लोअर लिम के बोन्स के फ्रैक्चर होते हैं तो दे स्टॉप वॉकिंग. सो आफ्टर दिस वी स्टार्टेड पुटिंग देम, जिनको भी हम स्टेरॉइड में बोन डेंसिटी कम आ रही है, वी आर गिविंग देम बिसफॉस्फोनेट लाइक एलेंड्रोनेट, या उनको इंजेक्शन शुरू करते हैं जस्ट टू मेंटेन द बोन डेंसिटी. So this was our experience and work related to Duchenne, related to steroid therapy. So that I conclude with saying that steroids are effective. They can improve the walking for at least 4 to 5 years if they are started on time. And if you want to start, then deflazacort is a better option. And you keep on monitoring for adverse events. They doesn't happen within one day. But when you give them steroid for 4 to 5 to 6 years, you anticipate कि some कुछ side effects आ सकते हैं. You keep on monitoring and modify your doses accordingly. But ऐसा नहीं है कि you start steroid and then you lose to follow up, and then we cannot undo the side effects if they happens. But we can monitor and we can change the doses and intervene to prevent them. Steroid की practice varies across the India, across the world. It's not used everywhere in the same fashion, but try to follow what the standard recommendations are given by the societies who works on Duchenne. and I strongly suggest that should be the part of treatment regimen of at least for children with Duchenne, because gain of 1 year to 4 year also is helpful for the child if he remains independent for ambulation. So that's a very, very important part. So this is our guidebook for Duchenne. What we give this to parents to have basic information. How do they monitor and how do we monitor? They can read, and this is in Hindi as well as Punjabi and English. So we just give to the patients who are registered with us and they are in our follow-up. So with that, I thank everybody for patient listening, and I'm happy to answer questions if there are some. Thank you so much.
Thank you, Dr. Renu. आपने बहुत अच्छे से समराइज किया, पूरे DMD के बारे में अच्छी तरह बताया, और मेरे ख्याल में स्टेरॉयड किस तरह से एक दोधारी तलवार है उसका भी आपने बहुत अच्छे से उदाहरण दिया। तो कई सवाल यहाँ पे हैं, कुछ एक सवाल तो मैं अपनी तरफ से पूछ देता हूँ जब तक लोग अपने हाथ उठाएं। एक सवाल था कि is steroid treatment available or any research for BMD patients?
So BMD may usually loss of ambulation doesn't happen so early. So by 18 years, usually they are walking. So for BMD, the literature is very scarce. So it is not very frequently used in DMD, but in children with Duchenne, it is definitely used.
Okay, thank you. What is the role of steroids in LGMD?
Okay, so LGMD may 1 or 2 LGMDs hai where some studies are coming, jiske liye they started using steroids. One is which we say is a congenital muscular dystrophy, which is also a variant of limb girdle muscular dystrophy, जो fukutin protein associated होते हैं, FKRP. So they just looks like a Duchenne, and Japanese people are using steroids in them. And sometime few cases has been used with the sarcoglycanopathies also, but the efficacy and data is still less for that. They are not really very much convincing right now to put them on steroids.
एक सवाल है, it's from a father who has 5-year-old son with DMD and deletion of exon 49 to 50. उनके 2-3 सवाल हैं। एक है, is there any website agency where patient data are registered for any clinical trial in India?
Right now, it's not available. Trials are being organized through individual institutes actually. So you need to find out and contact the principal investigator of that particular institute where if you want to get in a particular trial. So there is common platform is not available right now for India to enroll and to find a potential candidates. You need to contact individual institute जहाँ पे studies हो रहे हैं, and then get in touch with the PI and see inclusion exclusion कैसे हैं, so that if you have match with the inclusion exclusion, you can be enrolled.
Thank you. For treatment of DMD, steroids is the only option?
Okay, so I think that there are many speakers in the next sessions who are going to speak on exon skipping therapy or mini dystrophins, but practical issues are that they are not available in the reach of every patient. They are still through the trials or research, and it's difficult to purchase and get those therapies. So steroid is still indicated for all. On top of that, if you fit for any kind of study or any particular gene you have, then you try to get enrolled yourself in any ongoing studies or to get those therapies. But I'll say the drugs are limited availability, and it's not common to use these in clinical settings.
Okay, so there are many other questions, but they are very specific to individual conditions. So I'll request now Mr. Santosh Kumar to ask the question. Mr. Santosh?
हाँ सर, जैसे कि मेरा
सवाल पूछ सकते हैं।
सर मेरा बेटा 11 साल का है और उसको हम स्टेरॉइड में 6 mg दे रहे हैं। उसका वजन 33 किलो है। तो उसको स्टेरॉइड और ज्यादा मात्रा में दे कि उतना रहने दें? अभी वॉकिंग कंडीशन है, बहुत अच्छा है।
अभी एज कितना बताया आपने?
11 साल का है।
या सो 6 mg स्टेरॉइड का डोज बहुत कम है, जो मिनिमल 0.3 या 0.4 है उतना भी नहीं जा रहा है। सो द डोज उसका इंक्रीज करने की जरूरत है। एंड अगर उसका वेट गेन वगैरह ज्यादा हो रहा है तो हो सकता है डोज कम की जा सकती है, बट 6 mg पर डे वुड बी वेरी लेस डोज, सो यू नीड टू गो हायर, मतलब उसको बढ़ाने की जरूरत है।
मैम पहले बाइसलोन खिला रहे थे तो उसमें क्या हुआ था, वेट गेन बहुत ज्यादा हो गया था। तो फिर डॉक्टर से बार बार मिले मगर कोई सॉलिसिटी कोई डॉक्टर मिला नहीं मैम। तो उसके बाद हमने उनका बंद कर दिया और थेरेपी वगैरह चालू कर दिए। उसके बाद उसका वेट बहुत अच्छा लॉस हो गया और उसके बाद मैंने डिफ्लाजा कोड, जब मैंने देखा ग्रुप में सबके डिफ्लाजा कोड खिला रहा है तो उसको 6 mg से मैंने चालू किया है। तो
ओके,
उसको
सो
डोज आगे बढ़ाएंगे तो
या
प्रॉब्लम तो नहीं
सो
होगी?
नहीं नहीं, प्रॉब्लम नहीं होनी चाहिए। प्रेडनिसोलोन से मैंने बोला कि वेट गेन ज्यादा होता है, कशिंगॉइड फीचर्स ज्यादा होते हैं। डफ्लाजाकॉर्ड से वेट गेन कम होता है, बट फिर कैटरेक्ट और उनके लिए हमें ज्यादा मॉनिटर करने की जरूरत पड़ती है। बट जो मिनिमम डोज है वो भी नहीं जा रही है। सो यू नीड, आपका जो है, आप जिनसे भी सलाह करते हैं या फिजिशियन से मिल सकते हैं, एंड द डोज उसके बढ़ाने की जरूरत है।
संतोष जी, मुझे ये लगा आप ये कह रहे हैं कि आप खुद ही अपनी तरफ से डिसाइड कर रहे हैं कि स्टेरॉइड की कितनी मात्रा देनी है। हम
जी
यही चीज बताना चाह रहे हैं। पहले डॉक्टर विनय गोयल ने भी बताया, डॉक्टर रेनू भी यही बात कह रही हैं कि जनरली यही गलती लोग करते हैं कि कम मात्रा में अपने हिसाब से निर्णय लेके और उसका इस्तेमाल करते हैं। तो मेरे ख्याल में सुझाव ये है कि आप जहां भी रहते हैं वहां किसी न्यूरोलॉजिस्ट से संपर्क करके और इस डोज का जो भी उसको ठीक करना है या कुछ है तो सिर्फ आप अपने पैमानों पे मत देखिए, उनको
नहीं, वो
डॉक्टर से भी
दिखाए थे
बात।
डॉक्टर से, वो 40 mg
ठीक है,
लिख रहा था तो हमको समझ में नहीं आया, इसलिए मैं नहीं खिला रहा
नहीं
हूँ।
वो ठीक है। वो यही एक्चुअली यही एक बात है कि जनरली यही होता है। तो आप जरा संपर्क करके इसको जरा एक मतलब समझदारी वाला निर्णय लीजिए वैसे। ठीक है, ओके।
ठीक है सर, थैंक यू।
भारत एमडी फाउंडेशन, यू कैन आस्क योर क्वेश्चन।
नमस्कार सबको। मैं रमा लक्ष्मी बात कर रही हूँ सर। मुझे 2 क्वेश्चन है। एक है चांदक सर को, दूसरा मैडम को, मैम डॉक्टर जी को। मैम एक क्वेश्चन ये है कि स्टेरॉइड लेने से स्लीप में कुछ इफेक्ट होता क्या बच्चों को? स्लीप सोने पे कुछ?
या स्टेरॉइड से थोड़ा सा हाइपर एक्टिविटी, अग्रेशन, बिहेवियरल चेंजेस होने लगते हैं, सो दे कैन अफेक्ट द स्लीप आल्सो। सो थोड़ा बिहेवियर चेंज, पर्सनालिटी चेंज हो जाता है स्टेरॉइड थेरेपी से, but you need to take some measures to reduce that basically, but if they are intolerable we have to come, हमें फिर डोज कम करनी पड़ती है।
मैम पहले से ही ADHD और ASD पे है मैम, जो अभी स्लीप का प्रॉब्लम चल रहा है। If I start steroid for that boy, will it be reduced or it will be more hyper? वो क्वेश्चन पूछना था
द
हमको।
हाइपर एक्टिविटी में इंक्रीज, अगर जैसे मैंने
increase.
बताया था कि ड्यूशन का प्रोटीन ब्रेन में भी रहता है, सो
Okay.
IQ कम होना, ऑटिज्म, हाइपर एक्टिविटी, ये एसोसिएटेड होते हैं ड्यूशन में साथ में। तो अगर ये बेसलाइन है और इफ यू पुट देम ऑन स्टेरॉइड तो वो एग्रेवेट होने का रिस्क है, बट ADHD और हाइपर एक्टिविटी वी कैन मैनेज विद अदर ड्रग आल्सो, बट मसल वीकनेस वी कैन नॉट मैनेज विद अदर एनी अदर ड्रग। So you have to take a calculated decision कि कैसे करना चाहिए उसको, like you need to talk and discuss these issues.
Miss Ritu, you can ask your question.
मैम
रितु,
मेरा भाई है ना 26 साल का है अभी, और उसको है ना ये स्टीरॉइड देते थे हम लोग पहले, पर फिर जब डॉक्टर से बात की ना तो उसने ऐसा बोला कि अभी उसका वेट बहुत गेन हो रहा था, तो हमने डॉक्टर को दिखाया तो डॉक्टर ने बोला कि अभी 25 साल का हो गया है ना, तभी वो 25 ईयर का था, इसलिए अभी उसको असर नहीं करेगा, इफेक्ट नहीं होगा उसको। तो ये हम दे सकते हैं स्टीरॉइड या नहीं दे सकते?
अच्छा, वो अभी चलते हैं या नहीं चलते हैं?
नहीं, पूरा व्हीलचेयर पे है, वो चल भी नहीं पाता और अभी हाथ की मूवमेंट भी कम हो गई है, सिर्फ फिंगर काम करती है।
वैसे तो
और
देखो
अभी
ये
इसको ना थोड़ा बैठने में भी प्रॉब्लम हो रहा है, इतना टाइम तक बैठ नहीं पा रहा है।
ओके, सो इस सिचुएशन में जब एक बार चलना बंद हो जाता है तो डोज हम लोअर साइड में ही रखते हैं, लाइक वी कम डाउन टू मिनिमल पॉसिबल डोज। वो मिनिमल पॉसिबल डोज हम इसलिए रखते हैं कि ताकि उनकी हाथ की ताकत, उनका स्पाइन का टेढ़ापन और उनको सांस के लिए बाईपैप मशीन की रिक्वायरमेंट ना पड़े।
अच्छा, तो अभी मतलब उनको दे सकते हैं, बराबर है? और
या मतलब बिल्कुल जो मिनिमल पॉसिबल डोज है उसमें चला सकते हैं।
कितना 6 ग्राम
मेरा
कितना दे रहे
हेलो
मिनिमम?
हेलो मैडम,
हाँ,
हेलो मैडम, ये सुझाव ये है कि आप ये स्टेरॉइड देने का निर्णय अपने आप से न लें, क्योंकि जैसा जैसा डॉक्टर रेनू ने अपनी प्रेजेंटेशन में बताया कि सिर्फ ये पता है कि एक स्टेरॉइड से वजन बढ़ जाता है, एक स्टेरॉइड से नहीं बढ़ता है, लेकिन और कई साइड इफेक्ट्स होते हैं जो शायद आम आदमी को पता नहीं रहेंगे। और फिर उम्र हो गई है, आदमी चल पा रहा है नहीं, इन सब के ऊपर भी ये निर्णय होता है। तो सुझाव ये है कि आप वहां पे किसी डॉक्टर से संपर्क करके उनके सुपरविजन के अंदर में ये दवाई लें, ठीक है। मेरा अब आखिरी सवाल है मिस्टर नटराज का, उसके बाद में हमें ये सेशन क्लोज करना पड़ेगा। मिस्टर नटराज, आप अपना सवाल पूछ सकते हैं।
थैंक यू सर। मेरा सवाल मैडम से है कि मेरा बेटा जो स्टेरॉइड पे है 2 साल से, और वो डेली बेसिस लेता है, एवरी डे 15 mg। उसका वेट है 22 kg एंड इज एम्बुलेटरी बॉय। तो मैं किसी और वेबिनार में सुना था कि वीकली बेसिस जो डोज होता है वो ज्यादा इफेक्टिव होता है। तो क्या मेरा बेटा जो डेली बेसिस स्टेरॉइड ले रहा है, वो क्या वीकली बेसिस स्टेरॉइड पे ये स्विच ऑफ कर सकता है?
ओके, सो इसका आंसर सिंपल नहीं है, बट आई विल से जो बेस्ट एविडेंस है वो डेली थेरेपी के लिए है। लाइक जो सस्टेन्ड इफेक्ट जो बोलते हैं, जिससे कि एम्बुलेशन एक्चुअली इंक्रीजेस टू 3 to 4 years, वो डेली थेरेपी के लिए है। वो इंटरमिटेंट थेरेपी के लिए उतना स्ट्रॉन्ग एविडेंस नहीं है अभी, because you know muscles are contracting every time, so we cannot say that we'll give steroid for weekend and then उसका इफेक्ट 48 आवर्स या कुछ रहे एंड देन बाकी 4-5 दिन कोई इफेक्ट नहीं रहे, तो फिर वियर एंड टीयर की प्रॉब्लम ज्यादा है। सो व्हाट आई वांट टू से कि बेस्ट एविडेंस जो है दैट इज फॉर डेली यूज ऑफ स्टेरॉइड्स, दैट इज नॉट फॉर इंटरमिटेंट काइंड ऑफ थेरेपी जो 10 days ऑफ है, ऑन है, या वीकेंड्स हैं, या वीकेंड हाई डोज है, वो भी उतना इफेक्टिव नहीं है।
Okay, thank you, Dr. Renu. The last question from Mr. Ambrish from PPMD.
Ma'am, I wanted to ask you is when should the ACTH stimulation test be done if a child is unable to tolerate steroids for any reason, compelled to reduce the dose of steroids? Then when we should do the ACTH stimulation test to know whether the adrenal glands cortex have been revived or not?
I could not hear the question clearly. Can you just repeat it?
I said that when the ACTH stimulation test should be done in the case of child not able to tolerate steroids for whatever reasons and is compelled to reduce the dose of steroids, then when we should do the ACTH stimulation test to know if the adrenal cortex has revived before fully stopping the steroids, or is there we should do that in the intermittent stage, or we should fully stop the steroids and then only do the ACTH stimulation test?
So normally ACTH stimulation test is not recommended. Once anybody has received steroid for more than 2 weeks, their adrenal remains suppressed, HP axis remains suppressed for a year or so. So doing an ACTH stimulation test won't help you. What is known that whenever there is a stress, they have to be put on additional dose of steroids, like any kind of stress. So what is recommendation is that based on body surface area or meter, on depending on the stress kitna hai, like simple URTI hai, gastroenteritis hai, ya surgery hone wali hai, so then the steroid has to be replaced for that period, and steroid should not be never stopped abruptly. उनको अचानक से कभी नहीं बंद करना है. So you have to go very slowly to reduce. So ACTH stimulation का role ज़्यादा इसमें आता नहीं है. In fact, everybody has a adrenal insufficiency if you give them steroid for 6 months or so. Even a 2 weeks period of steroid, if it is more than given, that is more than 0.5 mg per kg equivalent दे दिया है, तो we assume कि उसका adrenal is suppressed, उसका HPX is suppressed है for the next 1 year, so he has to be on replacement doses whenever there is any additional problem with fever or any kind of stress. So ACTH stimulation as such for this decision is not required.
Okay, so that means that once you stop the steroids, your adrenal glands will continue to remain in the suppressed condition.
Yeah, they will remain not immunosuppressed. Their HP axis, जो hypothalamic pituitary adrenal axis है, वो suppressed ही रहती है, so they cannot form cortisol in a period of stress. जो ACTH उनको बनना चाहिए वो बनता नहीं है. So we advise them कि जब आप ले भी रहे हो, then you need to take a top up dose जब भी कोई stress आ जाता है. It's not like कि जब दस्त हो गया तो छोड़ दो या फीवर आ गया तो छोड़ दो, ऐसा नहीं है. On that day they have to take a double dose or increase the dose to 1.5 डिपेंडिंग कि आपका सिचुएशन कैसा है. So we never advise कि आप जब बुखार खांसी कुछ हो जाए तो दवा बंद कर दीजिए, ऐसा बिल्कुल एडवाइस नहीं करना.
Dr. Renu, just I can't stop myself from asking one question. जैसा मैंने यहाँ अभी जैसे कई लोगों से सुना कि स्टेरॉइड को लोग मतलब एक ट्रीटमेंट तो समझते हैं, लेकिन ये भी समझते हैं कि इसका इलाज वो अपने आप कर सकते हैं. साथ साथ ये भी है कि हर जगह एक एक्सपीरियंस न्यूरोलॉजिस्ट नहीं भी अवेलेबल हो सकता है, और प्लस हम जानते हैं कि कई क्लिनिशियंस बहुत इस चीज को कंसर्न नहीं देते हैं. तो ऐसी सिचुएशन में आपको क्या लगता है, कोई ऐसी कोई रेजिमेंट डिसाइड की जा सकती है या कोई एक गाइडलाइन डिसाइड की जा सकती है जो मरीज या उनके रिश्तेदारों को कुछ हेल्प कर सके?
I'll say they should be in touch with doctors to monitor the side effects, because side effects can be problematic at times. So steroid is recommended. You can give an additional 3 to 4 years of walking to that child. That is, I think it is a significant work which you can do. A patient who is losing his ambulation by 10 years, if he's remain independent for 13, 14, 15 years, I think this is a great help we can do. But it has to be monitored basically. So it has to be monitored. The minimum dose we know, maximum dose we know, which is the efficacious, but you have to keep the balance between an acceptable side effect profile versus where you want to intervene or you need to change the dose or regimen you have to change, that you need to take a call on individual basis.
Okay, right. Thank you very much, Dr. Renu. It was really, very nice interactive session, and I hope that patients और उनके relatives को काफी कुछ जानकारी मिली होगी. एक बॉटम लाइन मैसेज यही है आपकी तरफ से कि अगर स्टेरॉइड का इलाज चलना है तो किसी डॉक्टर से संपर्क में रहना बहुत जरूरी है. Am I right?
Right. So keep on monitoring, because monitoring is required. Abrupt stop, बिल्कुल एक दिन अचानक मन किया और stop कर देंगे, वो बिल्कुल नहीं करना है. And ये जो बोलते हैं कि फीवर के साथ आ गया, खांसी जुकाम हो गया तो बंद कर दो स्टेरॉइड, that is also a wrong practice. So what we actually have to increase the dose during the stress. So you are making them more vulnerable to that infection, the severity. So this things we explain the parents. We have that booklet with us. And we give them the parents to understand कि ये किस तरह से management रहेगा, because we have to be on the same level. What we are talking, they should be able to understand also.
तो आप वो बुक्स वगैरह हमें अवेलेबल करा सकती हैं मैडम? हम कुछ कॉपीज अपने पास रख लें और आगे मरीजों के
बिल्कुल सर करा सकते हैं. We have soft copies also.
Oh, wonderful.
If you want, we can share them. We have in Hindi, Punjabi, and English.
Okay,
and that can be translated. It's a very easy to read and very short book. We normally give when we make the diagnosis and counseling the parents. At that time we give that.
Okay, thank you very much, Dr. Renu. Yeah, thank you.
Thank you so much for the nice interaction we had.
Yeah. We will move to the next speaker.
Sorry, question है ma'am.
Yeah, we have one more question.
Okay, sorry. Yeah.
Hi, Dr. Renu. So I just wanted to understand the feasibility of corticosteroids for limb-girdle muscular dystrophy patients. If and what condition? And what about do we need to start any research for that? And is there already any findings for the same?
LGMD, our experience is limited because we see children maximum up to 12 years at the onset of the disease. Once we see them, then we continue to follow. but experience with steroid LGMD is very limited to myself. I think I'm not the best person to answer that question. An adult neurologist or myologist, they may be really able to help you. But in sarcoglycanopathy, steroids has been used, but the efficacy was not that much found, that so it is not like a standard of care for them. So it's not in the recommendations for them, as just it's like in recommendation for DMD that you should give them, but that is not true for all other LGMD. One FKRP Fukutin, it is coming, it will soon come in trials also, then definitely for those rare group of conditions it can be used. But for all, as a blanket LGMD, I would say that it is not, right now it's not a standard of care and not recommended. We don't use that.
Thank you very much, Dr. Renu. We have taken a lot of your time, and thanks for your patience.